this course is Pharmacology and Nursing. And this is an introductory course to get you used to dealing with medications and viewing meds in terms of what a nurse needs to know and doesn't know. So we're not teaching you to be pharmacists. So it's not important that you know things at the chemical level. We're not teaching you to be prescribers or healthcare providers, so you really don't have to know a lot of the content in terms at the cellular level, but we are teaching you to frame med administration in terms of how that affects our patients. So the term pharmacology, can you guys just put in the chat feature what you think pharmacology means, a definition of it? There we go. Study of medication. Good. So the correct definition, and you guys are right on, very good, is it is a study of medications or drugs and their effect on the body. So there can be a positive effect or there could be a negative effect. Now, has anyone heard the term nursing process? Ever heard nursing process? So nursing process, nope, is a foundational concept. So I'll be saying this to you when we get to areas in nursing that are going to carry you throughout your career, and nursing process is one of those concepts. So nursing process is a scientific framework that helps nurses in thinking through clinical problems and providing patient-centered care. So remember, that's our goal, is we want to provide good quality patient-centered care. But the nursing process gives us that system where we can set things up and think through. Now, there are 5 steps involved in nursing process. And I know that your textbook, especially in that first chapter, goes into quite a bit of detail of the nursing process. I want you guys at this point just to have a foundational knowledge, just to be able to identify ADPIE and know what those mean, because you're going to get 2 days of this lecture in 1710 in the 4th week of the semester. But when we look at the nursing process, it's made up of assessment, diagnosis, planning, implementation, and evaluation. So let's frame that in terms of med administration. So let's say that we have a patient that comes in that has a high blood pressure. So our assessment indicates that we have a high blood pressure, and you can kind of relate that back to what you did this morning in 1710 with those concepts of getting a blood pressure on a patient. Also involved in assessment is information gathering, not only physically what we see, but also what we find out from our patients. So we ask questions. Now, if I asked an open-ended question versus a closed-ended question, which type of question is going to yield more information? Right. So an open-ended question may be something like, tell me what's going on. Tell me what kind of medications you're taking. A closed-ended question is going to be more directive. So you're going to get more yes and no types of responses. So we have our patient that has a high blood pressure. That's our assessment data. And then our next step is diagnosis, or a patient problem. Diagnosis is just another word for a patient problem. So the patient problem may be that they're at risk for a altered perfusion state. Blood flow may not be getting where it needs to go. Then we go into the planning phase of nursing process. So the planning phase is, what is our goal for the patient? What do we want to see happen? Maybe the goal would be for their blood pressure to come down or to get within normal limits. And then we have the planning for our interventions. So what are we going to do to help this patient get their blood pressure down? Well, one of those interventions may be to give them an antihypertensive med to bring their blood pressure down. Then we have the implementation. So the implementation is what we actually do. So it would be going in and giving the medication at a certain time. It would be lowering the lights, turning off the television, maintaining a quiet environment. So those are the things that we actually do. And then the E in nursing process is evaluation. So assessing how well our interventions help the patient to get to their goal. So did their blood pressure come down? Is it the same? Did it go higher? So again, foundational concept, but as you're framing your care in giving meds, that's the scientific system that you're actually looking at. Now, another foundational concept is the 6 rights of medication administration. And you guys need to just commit these to memory. So they're the right patient, the right drug, the right dose, the right route, the right time, and the right documentation. Those are your 6 rights of patient administration. And if you will commit those to memory now and let that serve as your checklist before you ever give any medication, whether you're in lab, whether you're in simulation, whether you're in clinical, then that's going to be a safety check for you to make sure that you don't make a medication error. Now you'll notice the 3 down at the bottom. So you have current practice standards, you have the right reason or indication, and you have the right to refuse. So these aren't necessarily rights of medication administration. These are more standards. So I know Dr. Belknap talked yesterday, the patient always has the right to refuse. So if I go in to give a patient a medication and they say, I'm not taking that, can I force it down their throat or inject them with it? And of course the answer is no, I can't do that. But I used to work in the emergency room on Saturday night, and invariably we would get someone in that had drank too much or done too much of the drug. Could I put the charcoal down the lavage tube for those types of patients? Absolutely. They had lost their right to refuse because they had an altered mental state. And certainly if you have an altered mental state, then you get into a whole different issue. But again, let's don't go down that path. Just know that the patients have a right to refuse. We also need to make sure that we're giving it for the right reason or indication. And that's a good idea to note on the order if you have to take an order of why the provider or prescriber has actually ordered this medication. And then also adhering to current standards. So for example, back in the 80s when I started practicing, when we gave Phenergan, we would just give it IV push. The new standard is you have to dilute the promethazine before you would give a medication like that. So you just have to be current on the standards. Your Lilly textbook, which is your pharmacology textbook, says the 9 rights of med administration. I want you to disregard that. Your fundamentals textbook, your Wilkinson, says the 6 rights of medication. So you guys just focus on the 6 rights of med administration. And I want to spend quite a bit of time talking about medication errors. So what is a medication error? A medication error is a preventable event that may or may not lead to patient harm, but it still is considered a medication error. So flip your rights of med administration. So if it's the wrong patient, if it's the wrong drug, if it's the wrong dose, the wrong route, or the wrong time, those are all medication errors. So what we want to do on the front end is help to prevent these medication errors. IOM. Have any of you heard of the IOM, the Institute of Medicine? They're a pretty prestigious group in the world of healthcare, and part of, and it is where AMA comes in, Gabrielle, yes. I don't know about in mental health, but the IOM, they write a lot of initiatives, a lot of directives that really lead our practice. But the IOM found that there were 7,000 preventable deaths that occurred in 1999. Now I want you guys just to sit with that for a minute. 7,000 people. There are almost 100 of you all in this course. 7,000 people died because of a preventable error. Preventable means that it was either human error or it was system error. That's a lot of people. That's a lot of people. And certainly if it was my family member, it would be very significant. And I say this to help you guys realize how very serious med administration is. It is very serious and potentially very dangerous for the patient. So always make sure that you take med administration very serious. Now, as I said before, what we want to do is to prevent medication errors from even occurring in the first place so that we can stop those 7,000 deaths. And there are certain things that are in place in healthcare to help prevent those. So any medication error or any potential error must be reported. And there's a very specific chain of command that has to be followed in any facility, whether that be nursing home, whether that be the hospital, an outpatient unit, any area is going to have a very specific policy on reporting medication errors. But also I want to speak to this for just a minute. This is why nurses have to be ethical. You cannot have unethical people in nursing, because if you do, unethical people may not always report these errors or these potential errors. And how do we learn best? We learn best by making mistakes, don't we? When I've made the mistake, I don't forget that I have made that mistake. I try very hard never to make that mistake again. So we learn by errors. So it's important in our institution that they have a record of those errors so that they can learn what's breaking down in the system. It's also important in institutions that we have what's known as just culture. And just culture is an approach to medication errors where you don't necessarily blame the person, you blame the process. And so the process is evaluated. So I'll give you an example. If you guys have ever been on a hospital floor, you'll know that the med room typically is a room with locked doors. And the reason they have it in a room is because they want the nurses that are pulling out those meds not to be distracted. Now, in the old days when I started, we had a med cart that sat out in the hall. And I would go out there, I would pull out a bin, I would have people walking up and down, the unit secretary yelling at me, my coworkers talking to me. I had no quiet place. So the rate of medication errors was much higher when we had that type of environment. So because we had this reporting system, our hospitals were able to look at that and say, you know what, the nurses would do better. There would be less errors if they had a quiet room where they could go and prep those medications. And then we also have something known as CUSIN. So CUSIN, again, is one of those organizations that you're going to know about through the rest of your career. But CUSIN stands for Quality and Safety Education for Nurses. Quality and Safety Education for Nurses. And CUSIN helps to drive our curriculum so that in our curriculum, we help to point things out so that when you come out, you will be safer nurses. It's important that you know the difference between a medication error and an adverse drug response. So a medication error, as we said, is a preventable event that may or may not cause harm to a patient. It's a preventable event. So if I go in and give the wrong dose of insulin to a patient, that is a preventable event. Something happened down the chain that was missed and the patient got the wrong dose. An adverse drug response is when there's an undesirable effect of the medication. It goes a bit beyond a common side effect, okay? So common side effects are pretty predictable. You know that if you take, for instance, ibuprofen on an empty stomach, you know, there's a good chance that your stomach's gonna be upset or may hurt. An idiosyncratic reaction is an unpredictable adverse drug response. So for example, I had a patient that had type 2 diabetes and he was on a medication known as metformin. And he went into renal failure. Well, the reason he went into renal failure was because his body was reacting to the metformin and it put him in this state known as rhabdomyolysis. So those are big words. Don't worry about those big words, but just know that unpredictable responses can occur from medications. We also have under that umbrella of adverse drug responses, allergic reactions. So you see a picture here of someone that's having an allergic reaction. And when do we typically see allergic reaction? What's a pretty common med for an allergic reaction? Very good. So antibiotics. Antibiotics, it's pretty common to have an allergic reaction. So that is also considered an adverse drug response, but it is fairly predictable. Now, there are also medications that are more common in med errors. And one of the big ones is central nervous system drugs. And Dr. Belknap's going to be lecturing on this particular classification in 2 weeks. But those are things like opioids, narcotics, things that depress the central nervous system, things that contribute to respiratory depression. There we go. Another med that's pretty common in med errors is anticoagulants. So we're talking about blood thinners there. We're talking about warfarin or Coumadin. We're talking about Xarelto. So I worked with a nurse years ago, and this was a culture of the floor. We were hanging heparin, a heparin infusion pump, and heparin is an anticoagulant on a patient. And the way we would prime our tubing is we would set the pump to 999, which is a liter in an hour. Well, the nurse primed her tubing doing that, but she forgot to turn it off and put it on the right rate. So the patient was bolused an entire bag of heparin in an hour. Luckily, the patient didn't die, but the patient got 2 or 3 extra hospital stays because we had to put him on complete bed rest because of the risk for bleeding. So definitely common. So you have to really watch these meds and chemo drugs. And of course, we know chemo drugs are given on a chemo floor, and you have to be certified to give those chemo medications. Now we also have look-alike, sound-alike medications, and this is a big one. A lot of medication errors have occurred because of look-alike, sound-alike. Look at the spelling on buspirone and bupropion. I'm going to minimize the screen. Look, both pills are white. So you imagine you're working day shift, you've turned over 2 patients, you've ended up having 10 for the day. You've got 1,000 different things coming your way. And you see a new order. You see how easy it would be to get these 2 medications mixed up just because of the spelling alone? And then you reach in and you've got 2 white tablets. Now, granted, their shape is a little bit different, but still very easy. Look alike, sound alike medication. And this is another one, and very dangerous. So you've got morphine and you've got hydromorphone. Both come in vials. Both are clear liquid. Hydromorphone is 7 times as potent as morphine. So if you've got an order to give 1 milligram of morphine and you accidentally drop 1 milligram of hydromorphone, then we could have a problem with our patient. So be very aware of look-alike, sound-alike medications. Now again, many of the hospitals have set systems in place to help decrease this. For instance, they may make, if these 2 medications, the buspirone and the bupropion, were together in a dispensing, they may make them different colors to kind of draw your eye and alert you that they're look-alike, sound-alikes. They're, Carissa, they're basically the same. It's just a different way. Some people may call it salad, some people may call it Lassa, but it's the same. Medication errors can also occur during any step of the medication process. So look at all the steps involved in giving a patient a tablet of acetaminophen, a Tylenol pill. Look at all of the steps. Each of these steps involves humans. So there is a risk whenever you have someone touching something or someone involved that there's an error going to occur. So we have a dispensing system here, we have a provider here, we have usually the unit secretary or a nurse here, we have pharmacy here, and then we have nursing at administering and monitoring. So there's a lot of different things that can happen just to get that 1 Tylenol to the patient. I mean, look at this order. Can anyone really read this? This is what we used to do on night shift. Before they had the charting where they type it all out, which is just marvelous, but we'd all sit around and try to decipher at 1, 2, 3 o'clock in the morning what the physician had written. So it's definitely not easy, and look at all the errors that could have occurred from that, just from trying to decipher their handwriting. So it's big. Yeah, it is scary. Other issues that contribute to medication error. Organizational issues. So again, the system, the way they do things. Like I said, the culture, like the nurse I was talking about that primed her tubing with the heparin. We certainly had an in-service after she did that about what was correct and what was incorrect in terms of priming tubing. Educational system issues, sociological factors. So again, a lot of this has to do with the culture of the facility where you're working and the use of abbreviations. So again, another example of a physician's order that's very difficult to read. My suggestion is don't use abbreviations if you don't have to. you're going to have to know the abbreviations because people are going to speak it to you. You know, they're going to say, well, you know, we're going to do this BID, or we're going to do this TID, or HS, hours slept. So you have to know the abbreviations. But with all of the checks and boxes that you check and the lack of narrative writing these days, there shouldn't be a lot of opportunity for you to use abbreviations. And the risk is so high. It's just better to minimize that risk and not use them. And each institution will have a list of approved abbreviations that can be used. Now, what is the difference in a near miss versus a close call? So whether it's a near miss or a close call, those are both still considered reportable medication errors. So you would need to follow the chain of command if you have that event happen. But a near miss is an event that didn't produce a patient injury, but only by chance. So an example of this would be the patient received the wrong medication, or the patient received the wrong dose, or it was given at the wrong time. But thankfully, nothing negative happened to that patient. A close call is an event that was identified and stopped prior to getting to the patient. So for example, let's say that a pharmacy tech put the medication into the wrong bin. And as the nurse goes to pull the medication out and checks the package, sees that it's the wrong medication and doesn't give it to the patient. So that would be an example of a close call, and that would be a reportable event because the pharmacy tech may need further training. We may need to do something different in the system to prevent that happening again. Yes, so Ashley, it does become a sentinel event if patient harm occurs. It's a good question. Are near misses and close calls reported? Yes, Ravina, they are reported. So what else do we need to do to minimize those medication errors? Well, number one is you need to know that you have a voice, and you need to speak up when you see things being done that are not according to protocol. So for example, I worked with a nurse that was pulling up a narcotic one time. And rather than wasting the narcotic in the med room, which is what they're supposed to do if they have extra medication left over, she took the whole thing to the patient room and forgot to waste what was left and ended up giving the whole dose to the patient. So I didn't have to report her on that. It ended up being reported because it was a sentinel event. But if you see someone not following hospital protocol, then you need to speak up to those that are in charge. If you have orders that you can't read from a physician, you're not sure what they're saying, then you need to contact that provider and find out exactly what that meant. But you need to realize that you have the ability to speak up, because in the end, remember the whole reason that you're there, and it's to provide safe patient care. That's it. That's the only reason. So if you make someone mad because you've reported them about doing something, that's okay, because in the end, it's about you protecting those patients and providing good care to those patients. Also, computerized prescriber orders, or CPOE, have been a fairly recent event that's occurred in healthcare to help minimize errors. And you saw that on the example of the physician orders. Now look at this physician order. Look how nice that is. Isn't that beautiful? You can read everything. Everything's all written out. This is a dream for a night shift nurse to get an order like this. So the fact that they can now type those into the computer has really cut down on a lot of medication errors just because of trying to interpret. Thank you, Ashley. Most, Jonathan, when you're in the larger urban areas, but you still may have more rural settings, rural facilities that don't have the technology out there. But for us in the Knoxville area, yes, all of our hospitals do use electronics. We also have barcodes and scanning devices, which is, again, wonderful if it's done correctly. So again, you may have people that are bypassing the system that's set up, and the patients are going to end up suffering. So all of those medications are loaded into the electronic MAR, and if there's an error in the time, if there's an error in the medication or the dose, then that electronic scanning system will alert you if everything is done in that process. Automated dispensing machines. So again, many times pharmacy will come up and load those machines to help cut down on medication errors. In the old days, we had all our meds for 24 hours in one drawer, and you would pull that drawer out and you would get your meds set up. Now you do have to go through the technology, but the reason is to help cut down on those medication errors. And effective communication. So communication is paramount in healthcare. You know, you've got to talk to each other, again, to make sure that things are being done correctly. So types of medication errors. So what is the first one? No error, although circumstances or events occurred that could have led to an error. We already talked about that. You guys tell me, what is that called? Good. It's a close call. So an error didn't actually happen, but it could have happened if someone hadn't been alert and spoke up. It is reportable though. What about the next one? Medication error that causes no harm. Right. So there was a medication error that occurred, but thankfully the patient was not harmed as a result. So that would be a near miss. And then you get down to the sentinel events that we were talking about earlier. It's a medication error that causes harm. And unfortunately, it could even go down to an error that results in a patient's death. So we have multiple systems set up in place. Again, the checks and balances are there, but we have to go through all of those steps to make sure that our patients are safe. So Jennifer, if there's no actual error, if there's nothing that actually was done incorrectly on the part of a person or the system, then that's not a reportable event. But if you have an adverse reaction, if a patient had an adverse reaction, yes, Rebecca, like an idiopathic or an allergic reaction, then usually the medication is changed or the dose is changed. So something will end up happening. The patient wouldn't get that same dose or that same medication if they had that adverse reaction, like the patient I was telling you about that went into renal failure when they were on the glucose medication, metformin. So they immediately took the patient off that medication. Of course, he had to go through dialysis, and then they put him on a different kind of medication. We've talked about prescribers writing legibly. And what do you do if you sit down to input an order and you can't read it? Let's say that you're in a rural setting that doesn't have electronic orders, or maybe something is missing from the order. Right, Ashley, you call them, call to verify. Even if it's 3 o'clock in the morning? Yeah, Because again, why are you there? You're there to take safe care of those patients. So always keep that in the back of your mind. I used to take a deep breath because I worked on a cardiac floor. So I was dealing with people that were, you know, almost at God level in their mind, cardiovascular surgeons. And I couldn't read their writing, or it didn't make sense. And I would have to call them in the middle of the night. You just have to take a deep breath and go, all right, here we go, because this is for the good of the patient. And then, you know, once the yelling stopped, you know, then it's like, okay, they would calm down and give you what you needed. If you can't read the physician to verify, you're going to find an admitting physician, Angela, so you could contact the admitting physician and they would let you know. Because the physician that wrote the order may not be on call. It may not be, it may be a different provider. Also, your references are very important. So, you know, I told you guys about the promethazine or Phenergan. That's changed a lot than when I first started practicing in terms of how you give that. So if I pulled a drug reference guide out from 10, 15 years ago, that's definitely not going to be current. So you want to make sure that your reference guides are current, and that's no older than 5 years. But when you go into a hospital, if they have a pharmacy, they're going to have a formulary, which is what they use to dispense those medications, and that is your guide. You usually can pull those formularies up on one of the computers on wheels, and it will show you exactly how you give the medication, what the correct dosage is, the right amount of time to give the medication. So all that information is in there is correct. Because would you ever give a medication that you didn't know anything about? If physician writes a new order, no. You don't have to know everything when you're a nurse, but you do have to be willing to take the time to go look it up and find the information that you need so that you keep your patient safe, because nobody wants to be responsible for the medication error. Absolutely nobody. So make sure that the information that you're getting is correct. And that's a good thing for you guys to do when you go into the clinical setting. You know, when you have some downtime, is to find where the formulary is so that you'll know what the hospital's protocol is on giving certain medications. Now, we talked about the 6 rights of med administration and how you need to commit those to memory. And the reason that we have those 6 rights is to protect our patients. But we also have 3 checks for every medication that we give. So you need to check, you need to recheck, and you need to triple check when you're doing med administration. And we'll talk more about that when we get to med administration in intro, but just realize that it's very important not to skip those steps. So when you go to get that medication out of the med room, you're going to check to make sure that you've got the right medication, the right dose, you're going to give it the right time, you've got the right route, and you've got the right patient's MAR. When you draw up that medication, you're going to check all the same things again. And then when you're at the bedside, you're also going to check those 3 checks one more time. Now, there's something that I didn't mention that you also need to check when you've got that medication out and you're looking at it. Does anybody know what it is? Expiration date. Good job, Jonathan. Yeah, so you've always got to check the expiration date. Again, pharmacy is supposed to check those meds and pull the ones that have expired, but you're giving the med. So it's your responsibility to check that expiration date and make sure that it hasn't expired. Assessment. So the first thing a nurse does, whether they're giving meds or doing any type of skill or procedure, is assess their patient. So we want to assess our patient first. So let's say that we're giving a blood pressure medicine. Remember, we had that patient that had the high blood pressure. So we're going to give a blood pressure medication. What is the first thing we're going to assess on that patient before we give a blood pressure medication? Very good. We're going to assess their blood pressure, because if we give their blood pressure medication and their blood pressure is already low, let's say it's 90/60, what's going to happen to the blood pressure? It's going to drop, right? It's going to tank. It's going to bottom out. And then you've got a situation with your patient. So assessment is key. 2 patient identifiers before you give any medication, even if it's just ibuprofen, acetaminophen, and aspirin. You have to follow the policy. And all policies say that you have to identify your patient 2 ways. So typically what you're going to do is you're going to go to the bedside with your computer on wheels. Very good. And you're going to look at their armband, and you're going to ask them, tell me your name, and you're going to read what's on their armband and make sure that it matches, and tell me your date of birth. Very good. And then, because you've got your MAR pulled up on your computer, you're going to look and make sure that you've also got the correct patient pulled up there, because you scan their armband and their MAR will automatically pull up. So you've identified your patient 2 ways. What else can you check at this point that's very important before you give medication? Allergies. Very good. So allergies. So are you allergic to anything? Also very important, because after you've given the IV push morphine and the patient said, oh, by the way, I'm allergic to that morphine you just gave me, you can't suck it back out of the syringe. So you want to ask them ahead of time, what allergies do you have? What do you do if you have someone that's not a reliable historian, that's maybe been confused? How are you going to identify allergies? You can look at the chart. You can look at the MAR. If there's a family member sitting there and they're a reliable historian, you can ask the family member. More than one occasion, I've had family tell me one thing, the chart say something else, and the patient say something else. So if the patient is competent and reliable, then I'll listen to my patient. Okay, you're awake, alert, and oriented times 3, and you're telling me you have no allergies. And you might even document that. But the main thing is include that when you do your identifiers, and that can help. Never administer a medication that you haven't prepared yourself. And I'll tell you guys a secret. Unfortunately, there are a lot of people in nursing that have substance abuse issues, and it has to do with it being so readily available. And remember that ethical piece? So people that are abusers, and they may look normal, are always willing and ready to help you out with those narcotics. Oh, here, I've drawn up your morphine so you wouldn't have to go do it. That's okay. You go with somebody else and waste that morphine, I'll draw up my own morphine. So don't ever take anything like that, because your license is the one that's going to be on the line. So you draw up your own medications. You also want to minimize verbal or telephone orders. So again, this can't always be helped. You work night shift, you're not going to have providers there with you a lot of times, so you may have to call them. But again, we want to minimize errors. So we've got some very specific rules that help to minimize those errors. One thing is you always repeat the order back to the prescriber. Okay, you want me to give furosemide 20 milligrams IV push stat. And oh yes, that's exactly what I want to give. If there's any doubt about the medication, like what we saw with the Buspar versus the bupropion, spell the drug. Hang on, let me spell that drug and make sure I know what you're saying to me. Are they going to be irritable? Probably. Is that okay? Yeah, that's all right. That's all right, because again, you're doing what's best for the patient. And speak slowly and clearly. So when I worked in the ER one night, I had a patient who had a potassium of 7.1. And again, it was night shift. So I had to call the on-call physician, and he told me to give this medication. It's called K-Exolate, and it helps to lower the potassium. And we always gave it rectally in the emergency room because it lowered it pretty quick. He told me to give it IV. You can't give K-Exolate IV. And it was 2 or 3 in the morning, and I said, are you sure you want me to give it IV? And of course, at that point, you know, he kind of woke up. He said, oh, no, don't give it IV, give it rectally. So it's okay to advocate. It's okay to speak up. You can certainly do that in a professional way. And list indications next to the order. So if you have to take those verbal or telephone orders, then list why that particular order is being given. Never assume anything about an order. So I don't know if you guys noticed it, but on that automated or computerized order that I put up there, it didn't have the route for the medication. It didn't say PO. It said tablets, but do I assume that it's PO? No. The order has to be complete. So you would call the provider and say, I know you've got tablets on here, but you didn't write the route. So you have to include the route. So never assume anything. Oh, you know, he meant that to be 25 milligrams of promethazine, not 250 milligrams. You don't assume that. You call and get the order to correct it. Why do physicians get so flustered? Because you have to consider that you may be the 75th person that's called that provider. So they usually admit to various facilities, and they have a lot of patients in the hospital. They have people calling from home, and so they have a lot of people contacting them. So it's tough. We talked about questioning. Don't ever hesitate to question. Again, remember why you're doing what you're doing, to provide good care to your patients. Don't try to decipher illegible orders, and don't use unapproved abbreviations or acronyms because they have a complex. Okay, well, that was your answer, not mine, Autumn's. I'm just going to touch on this, but Professor Arnapol is going to lecture on this next week, and it has to do with writing those medication orders. Very seldom do you ever use the word never in nursing, but this is an example. So you never use a trailing zero. Do you see if I was going to give morphine and I didn't see that little dot because, you know, I got to wear these glasses all the time and my eyes are old, I may give 10 milligrams of morphine. Big difference in 1 and 10. So you never use a trailing zero. On a number that is less than a whole number, you always use a leading zero. So again, my eyes are old. I don't see this little dot. So I think it's 25 milligrams instead of 0.25 milligrams. A big difference. Yes, and so Chloe, the rules for answering dosage calculation questions is above every dosage calc question you have on an exam. So the rules are there. So you need to remember those, but the rules are definitely there for you. But you'll get more of that next week. So take time to learn special administration techniques of certain dosage forms. So again, you know about your med. You know if it's given rectally, you know if it's given vaginally. For those of you that are in healthcare, we've had patients who were taking a rectal suppository and swallowing it as a pill. They didn't understand what we had said. So you have to know about those routes and how to give the medications and make sure that your patients understand. Always verify new medication orders. So when new meds come up, Make sure that you verify them and confirm them. Read your labels. Very important to read those labels again. If you have an electronic scanning system, if you scan it, it will pick it up automatically what that is. And you have to learn to use the generic terms. So for years we did not. We used the brand names, and they're so much easier to say. I have a hard time getting through all the words that we've got to say now with the generic. Now I'd like to find the person that named some of these meds and give them a piece of my mind. But anyway, we've got to learn to use the generic terms. And that's what you're going to see on your exam questions, because that's how NCLEX is. You're going to see those generic names. So as you're learning meds, you learn them generically. Yeah, so good question, Jennifer. And we're actually going to get to that in a minute. So you have, actually, that may be my next slide. It is. Yeah, let's go to the next slide. That's a good question. So there are some medications that you have to have a second nurse verify. And those are medications that are very, very dangerous. So insulin is a very dangerous medication if patients get too much. And because we give such small amounts and we measure them in a different type of syringe, you always want to have a second licensed person. You can't get the CNA. Has to be either an LPN or an RN to actually check you off and make sure that you've got the correct dose. We actually had a nurse one time that was drawing up 5 milligrams of insulin. Well, normally you never give more than a cc, a milliliter of insulin, but she was drawing it up into a big 5 cc syringe because she saw 5, and it's 5 units, not 5 milliliters. That could have killed that patient, but thankfully someone caught her in time. So you have to have a second licensed person. The other medication is heparin. So IV heparin, sub-Q heparins have to be checked by a second licensed individual, and those are blood thinners. We talked about allergies. We talked about looking up information on your medications. It's very important to listen to your patient. So if you're getting ready to give a medication and the patient says, I don't take that pill, that doesn't look right, what are you going to do? You're going to say, oh, it's fine. You'll be fine. Take this. It's okay. Very good. So you always go back and double check. You listen to your patient. If your patient says something, then you go back and double check. I wanted to look back up at these questions. I didn't want to ignore your questions. After the insulin mistake, did that have to be reported? We reported it as a close call. Yes. When giving medication, don't you have to stay with the patient to make sure they don't choke? Yeah, you can't just hand a patient the pill. So you have to make sure that the patient has swallowed it, and then after they've swallowed it or after you've given the injection, then you go in and you hit save on your electronic charting, and that shows that the medication has actually been taken. So good questions. Very good. Minimize interruptions. So, we talked about the medication room. This is not the time to be texting with your family back and forth about the dog getting out when you're preparing medications, or to be checking your Facebook. So when you're in that med room and you're pulling up those medications, you need to be focused on what you're doing. So again, that's why they have those in locked rooms, is to minimize the interruptions so that the nurses will be focused. Reporting medication errors, we've talked about that. Let's talk just a little bit more about the specifics. So if you realize that there's been a medication error, what is the first thing that you do? What about your patient? Why are we there? check your patient. So the first thing you do when you realize the medication error has been made is, yes, very good, Margaret, you assess your patient. You go in and assess and stabilize and make sure your patient is okay. Once you know your patient is okay, then you're going to report it to the charge nurse, then you're going to report it to the provider, and then you're going to fill out your incident report. Now, there are also external reporting that occurs, and this is how the IOM got that information back in 1999, is through these external groups where medication errors are reported as well. And that's something that the hospital will take care of. So that's not something that the nurse has to do at the bedside. And then the last piece in medication errors is medication reconciliation. So this is just a process to make sure that there are no discrepancies between medications that the patient was taking at home and medications that they're taking at the hospital. And this goes on throughout the patient's stay. So let's stop there. We're going to take about a 10-minute break, but let me ask first, are there any questions about medication errors or the nursing process? And Ibrahim, it looks like, what about vomiting out pills after intake? Do you repeat again? No, Ibrahim, you would let the provider know and let the provider decide what they need to do. They may need to change the route of the medication. It may need to be given IM or IV. To clarify, if given the wrong med, tell the patient immediately, then assess. If you've given them the wrong med, and you're going to develop this in nursing school, you develop a poker face. Okay. Now I don't do very well with poker face because I'm older now, so my poker face has gone away. But if you've given the wrong medication, then you very quietly make sure your patient is okay, assess your patient. You don't want to cause them any undue alarm. At some point, you will let them know that something has happened, but once you make sure your patient is physically stable, then you go and you notify the charge nurse and the provider. You've got other things that you've got to get in place. So if the patient really needs the medication, let's say that they've got fluid on their lungs and maybe they need furosemide and they refuse it, then if they are cognitive and able to make informed decisions, then yes, you would just document that. That's within their right. And to let the RN know ASAP. Yes, you do let the patient know any side effects, and it's a great opportunity to do that when you're at the bedside. Would you later contact the family as well? So Amber, under HIPAA, you can't do that. So you would let the patient know, but you can't release that confidential information. Whew, you guys have a lot of questions. Yes, you can tell them, Kimberly, what can happen if they refuse. So if you refuse the furosemide, I just want you to realize that we're not going to be able to get the fluid off as quickly, and you're still going to continue with having problems to breathe, and your heart's going to have to work harder. So yes, you do need to tell them that, and you also need to document that. You're welcome. It's not their right to refuse meds. So Alexandra, if they are cognitively unable to make informed decisions, then yes, they lose the right to refuse their meds, like what I told you about the patient that attempted suicide and the patients that were drug overdoses. Then they lose the right to refuse for me to put an NG tube down their nose and give them charcoal. I have the right to do that. If their family member is their power of attorney, and again, they're not cognitive to make a decision, Amber, then their family member makes that choice. Someone is able to make informed decision, need to be documented already that they are unable. It needs to be documented already. It wouldn't be the nurse's place to make that decision. Yes, we are taking a break. Yeah, so let's take just a 10-minute break because I need you guys to come right back so we can finish up that lecture and Professor Arnapol can get started. No, the implementation step, Anna, is the nurses. That's what we actually do, whether that be taking vitals, assessing, giving medications, educating. That's what the nurses do. Bradley, that's a sticky question. I don't do pediatrics, partly for that reason. My area of love is geriatric patients. If it is a life-threatening situation and there is no parent or guardian, legal guardian there, then they can go ahead and have implied consent. But that would be in a very rare instance. So Jennifer, if a family member is in the room, it's okay to answer general medication questions. And you can always ask the patient, you can say, is it okay if I speak in front of your family member about the medication? And if they say no, then you would politely ask the family member to leave the room. If they say yes, then you can go ahead and discuss things, you know, within reason. But you always want to make sure that you have the patient's consent. You're welcome. All right, let's go ahead and get started back. So now we're going to talk about lifespan considerations. There's a big difference in giving a medication to a newborn versus giving a medication to a 35-year-old versus giving medication to a 90-year-old. So part of what we have to do as nurses is we have to factor in their developmental place, where they are in terms of their physical as well as their mental development, because that's going to greatly impact the way we give medications, how compliant our patients are. But I want to really focus on 4 groups that need special consideration. We're talking about women that are pregnant, newborns, pediatrics, and older adults. So let's start with pregnancy. So a lot of medications, not all, but a lot of them can cross the placenta and actually harm the development of the fetus. So if you see this picture down at the bottom, this was a baby that was impacted by a drug that came out in the 50s and 60s that was called thalidomide. And thalidomide was given to women for morning sickness. So they were taking it, and there unfortunately were a lot of babies that were born with flippers for appendages. They took the drug off of the market, thankfully, but actually the drug has come back on the market, and it's used to treat leprosy and several other skin conditions. But now we have the FDA in place that regulates the medications, and they require that all packagers put in those medications how it will impact fetal development. And so there are 2 different systems that actually are in place right now. The original one was a classification system that went from A to X, and you can look on page 34 in your Lilly textbook, and there is a table, it's table 3.1, that condenses all of those categories. So if a medication falls under category A, there's been no evidence that it affects fetal development. If it falls under category X, there has been evidence to support, like thalidomide, that it does impair fetal development. Now, as nurses, you guys don't necessarily have to know all that information because you're not prescribers, but what would it be important for you to know? Very good. Good, Madeline. If the patient is pregnant, so you have a female of childbearing years, then it's going to be very important that part of your assessment is finding out if that patient is pregnant. But the new rule actually breaks the categories into subsections. So it addresses patients who are pregnant. It addresses patients who are lactating, because some meds can be passed to the baby. So for instance, women that are nursing, they're not going to typically let them take high doses of opioids because the baby will get sleepy and won't feed as much if they're lactating. And female and males of reproductive potential. So what do antibodies do to birth control pills? Right. They render the birth control pills ineffective, or it lowers the ability of the birth control pills to work. So it's important that we have good information on these patients. But realize also that you may see both on FDA packaging. You may see this A to X profile that's up, or you may see the new rule. I don't want you to get bogged down in all of that, but just realize that that will be on all these medications, the category. We also want to talk about infants. So when we talk about infants, we categorize them as newborns. So a neonate is 0 to 30 days. That would be considered a neonate. A newborn is going to be from 1 month up to 1 year. So what do you think it's important when you talk about infants or newborns or neonates when giving them medications? Very good. Weight. Weight is very important because when you have a system that is very underdeveloped, that is very small, then dosing is going to be really important. And the way providers decide what dose is based on the infant's weight. We also see this with pediatric patients. So we'll see it with toddlers, preschoolers, school-age children, and that's considered age 1 to 12 is a pediatric patient. And then of course you have adolescents that are considered teenage years. What do you think some things that are going to be important if you're dealing with a preschooler? What are some things we'd want to factor in when we're looking at med administration? Vaccinations? Can they chew? Can they swallow? Allergies? Route? Flavor? Right. Can they follow commands? You know, do they listen? Are they able to swallow things? So a lot of different things that you have to take into consideration when you're planning how you're going to deliver medications to different age groups. And then we have older patients. So older patients are defined as anyone that is 65 years and older. And we see certain things with older patients that we really want to watch for as nurses. One is that organ function declines. So liver function declines as our patients continue to age, which means that meds are not going to be metabolized as quickly. Kidney function declines with older patients. Very good, Alexandra, which means the meds aren't going to be excreted as effectively. So those medications in an older patient can build up. So you may be able to give a dose of hydrocodone to a 35-year-old, and if you give that same dose to an older individual, they may end up being very sleepy, very lethargic, they may end up being confused. So we have to take that into consideration when we're dealing with an older population. And you guys are going to have older patients. Older patients are very common. Polypharmacy is something else. Poly meaning many, pharmacy meaning medications. So these patients are on a lot of medications. Typically, I've taken 9 o'clock meds into patients. They'll have 12, 15 medications at a time. So they can be on a lot of medications, and those medications can interact with each other. They can cause very negative, unpleasant side effects, making the patients refuse the medication. I'm not going to take that. You know, if I'm sleepy all the time, if I'm nauseated all the time, I'm not taking that. So you may have compliance issues. You also may have motor deficits. So patients may not be able to get downstairs to get their medications. They may not be able to go out and get their medications. That's been one of the good things about this virus, is that it has really ramped up the home delivery system. And I did home health for 15 years. So there's a lot of older patients that can't get out and get their meds. So that can be a real issue. And sensory issues. So patients may not be able to see the pill bottle. They may not be able to manipulate the pills. The pills can be very small. They may have fine motor issues. There may be cognitive issues. I used to have a patient, and he cognitively was there, but his wife had Alzheimer's, and she would hide his medications every other day. So when I would go, the first thing I would do was like going on an Easter egg hunt. I would have to go find his medications in the house, and then once I found them, I would bring them back. So, you know, there were a lot of issues going on. So we really need to assess that and be looking for that in patients that are older. So that's just kind of an overview of that special population. We also need to assess culture when we're looking at med administration. So ethnopharmacology is just a very big word to talk about culture and medications. So when we're assessing our patients, we need to also assess their belief system about health, some of their practices. Medications may have different meanings for different people. Can you guys think of some barriers to patients being compliant with their medications in terms of their culture, their heritage, their ethnicity? Jehovah's Witness in the blood against their religion, birth control, pork and insulin. Yeah, insulin used to be made from pork. Veganism, herbs. So yeah, how about cultures who believe it's a sign of weakness to take a medication? Have you ever experienced patients who are afraid to take narcotics because they're afraid they're going to get addicted? I mean, I've had patients that are in end-stage cancer and are afraid to take the opioids because they're afraid they're going to get addicted. They could also view it as giving up part of their heritage. You know, there's a lot of home remedies involved in different cultures, herbal remedies, folk remedies. So I don't know what you guys were brought up with or things you're familiar with, but you know, a lot of things can really impact a patient's compliance to take their medication. And so that's something as nurses that we really need to investigate and we need to factor in when we're planning our patient's care and looking at that nursing process. How about their past use of medicine? So have you ever taken a medicine that made you sick at your stomach or made you have a bad reaction? What's that stuck in your mind about that medication or about taking pills? Yeah, so finding out what's happened in the past with, yeah, I don't want it ever again, never take it again. And patients will do the same. I'm not taking that. That makes me sick at my stomach, or that gives me a headache. Or again, going back to my patient that was on the metformin, he probably is going to be very reluctant to take metformin because he went into renal failure because of the metformin and the adverse reaction. So knowing this information, again, pulling that all in to make a complete care plan as you're looking at how you're going to help these patients be compliant, what information you need to give them, that type of thing. So you guys have any interesting folk remedies or herbal treatments that you're familiar with? I used to have one patient that swore by beet juice for kidney stones. What would the elderberry be used for? Janie, smudging. It's going so fast. Colds, okay. Cranberry juice for migraines. Okay, that's interesting. Mustard and vinegar on burns. I have heard that. Onion and sock. That's interesting. More muscle cramps. Okay. Zinc for colds, white vinegar for sunburn, chamomile tea for cramps and insomnia. Yeah. Yeah. So, you know, there's a lot of different folk remedies and herbal treatments that are very prevalent. And you need to know about that because some of those treatments can interact with the medications. Those are all really good. Thank you all for sharing those. Beer or Canada Dry? I didn't see that one. Honey a day keeps the cold away. Urine in the ear. Oh, what is urine in the ear for? I have to know that one. Use that for earwax. Sweet oil for earache. Urine in the ear for ear infections. Huh. Well, that's interesting. You know, I had a patient once when I was a student that was going through DTs, and he urinated into his urinal. And you know, fresh urine is yellow and has that nice frothy head on it. And then he drank the urine. So I asked my instructor, I said, now is that intake or output? I'm not sure. Seems like it just canceled it out. So she said, just don't worry about it. So yeah. And the last thing we're going to talk about is patient education and drug therapy. So as nurses, we are pivotal in terms of educating our patients, and primary in terms of patients having information that they need. You know, how many times have you been at the doctor's office and the doctor comes in and tells you, I'm going to start you on this new medication, and they turn around and leave, and then what do? You look at the nurse, right, and say, wait a minute, well, what is this medication? Tell me about this. So they're going to look to you, Google, to answer those questions. Yes, there's a lot of people on Google now, you're right, but they're going to look to you also to answer those questions. And you can't pull up your phone because you can't, you know, have it at the bedside as a student. You got to know those medications. So that's why we want you to be prepared now. But again, when we look at ADPA and we're looking at patient education, assessment, so knowing what meds that they're taking, finding out about their mobility, what about their nutrition, things that we've already talked about. It's all part of that assessment that you're pulling in, that nursing process. Looking at their readiness to learn. So if we look at this poor guy sitting up in the bed, he's obviously in distress, right? Does he look like he's ready to learn about the daily ibuprofen he takes at home for his arthritis? No, not at all. He's in distress. So if I give him, let's say if I give him an IV dose of furosemide, which is a diuretic or a water medication to get that fluid off his lungs, would it be appropriate to say to him, after I've gone through all my checks and allergies, I'm going to give you this medication, which is furosemide, because it's going to help pull that fluid off your lungs and help you to breathe better? Is that appropriate? Yeah. So your mouth may get a little dry. You're going to definitely urinate a whole lot more. So that certainly would be appropriate, but we're going to keep it brief. But let's look at our other lady over here. Would it be appropriate to go to her and say, you know, let's talk about that daily ibuprofen that you're taking at home for your arthritis? Yeah, she looks ready, right, to get more extensive teaching. So a lot of what nursing has to do with is emotional intelligence. It's picking up on those cues. You know, I would worry about a nurse that would barge into this guy's room and say, all right, now let's talk about the antibiotic you're going to go home on. That's not the time or the place. So you've got to pick up on your patient's cues, all part of your assessment. We talked about mobility status, their self-care ability, you know, how is that going to be impacted? We talked about sensory status. Again, looking back at our ADPA, we have D. What does D stand for? Do you guys remember? Don't look back. Good. Diagnosis. Diagnosis is just diagnosis. Diagnosis is just another name for a patient problem. So it's identifying a patient problem. Maybe they're non-compliant with their medications because they can't see the bottle well enough. What about the P? What's the P stand for? Planning, right? So we're planning goals. What do we want the patient to achieve? We want them to be compliant with their medications. Planning the interventions. What are we going to do to help them to be compliant with their medications? Are we going to call the pharmacist and say, you know, can you print a bigger label because the patient can see? Can we contact the family member and say, could you get a magnifier so they could see the labels? And then I, what's I stand for? Implementing. So implementation is the actual doing. So we're actually calling the pharmacy, we're actually assessing, we're actually giving the medication. And then what's the E for? Evaluate, right? So we're evaluating, We're asking questions. We're validating. Have they learned anything? Do they understand why they're taking the ibuprofen? Do they understand why I'm giving them the IV furosemide to get the fluid off? If they're giving themselves an injection, have them return that back to you. It's a lot easier to go in and do it yourself, but it's not what's best for your patient, because your patient's going to go home and they're going to have to be independent, or the family member or the caregiver. So have them do a return demonstration. So all of these things are really important in terms of pharmacology and nursing. But remember, we're talking about how those medications are interacting on the patient's body, and we're always incorporating nursing process into that. What's the acronym you just did? ADPI? So that's on one of the first slides, Rebecca. It's for the nursing process. What other questions do you have? That's okay. Okay. Compliance versus adherence. Very same, I mean, very similar. So they're compliant, they're doing what they're supposed to do, they're adherent to the regime, they're doing what they're supposed to do. I would consider those really the same. Is diagnosis a part of the human needs statement? Identifying a patient problem? Yes, it would be a part. You're welcome, Tamara. Other questions? Who makes the call on if a patient is cognitively responsible for themselves? The provider. Yes, the provider would make that call. Now, if you're taking care of a patient, and I've had elderly patients do this, I'll go in and they'll be pleasantly confused. You don't know they're confused until you start to have a conversation and you realize they think it's 1965. So, you know, sometimes they can not mislead you, but you know, you really don't realize that they're confused. If it's not documented in the chart, then you're going to need to call the provider and let them know what's going on. What if a patient declines one drug because it makes them feel bad? Can the nurse give a similar drug? No, they can't replace it, Kimberly, on their own. They can call the physician, and for instance, Tylenol number 3, you know, it's Tylenol with codeine, was notorious for causing nausea. And so you could call and say, you know what, the patient has a lot of problems with codeine and Tylenol. Is there another med that we can give them? So certainly we would want to alert them to that. If a patient doesn't want to take a med because they Googled it and don't like the side effects, do we skip all meds to keep the right time and contact the doctor immediately? So that's actually a good question, Christy, about time. Typically what facilities will do is they will give you a window of time. So there's no way that you can give 8 patients all their medications at 9 o'clock on the dot, but they normally will give either 30 minutes before or after, or they may give an hour before or after. So if you have a 9 o'clock med, many times you'll have a window from 8 to 10. And as long as you fall within that window, then it's not considered a medication error. But you can put a hold on that medication and go ahead and give them the meds, because you would never want to just leave the pill cup or the medication sitting there unattended. If you leave the room, the meds go with you. Ginger, it depends on the facility. So I've been in some facilities, it'll be 30 minutes before or after. I've been in other facilities where it's an hour before or after. So you just have to know your facility. And when you guys start giving meds, next semester, your clinical faculty will know that policy. If the patient vomits a pill right after or minutes after administration and it's essential that it's taken, what do? You contact the provider, and you need to examine the contents to see if the pill was dissolved at all. You're welcome. Other questions? You guys have some great questions. Very involved. You've done very well for the first day. Well, if you think of any questions, don't hesitate to email me, and I'll be happy to get back in touch with you. And I will stop sharing my screen and see if Professor Arnapol is on there. There he is. There you are. Okay. So they
all
came
right
at 1:10. They had a break till 1:10.
Okay.
You guys have a good rest of the day. Thank you.
All right, let me get the share screen going. Couple quick things while I'm getting set up. Just so you know, I made that discussion board that was requested under class of 2022. So you have one there. All right, can we see this? Yes, we can. Perfect. Okay. We may or may not get through all of this today, and that's okay, because next week I've got 3 hours of dosage calculation with you. Unless you want to do 3 hours of dosage calculation, I will do my best to make sure you have part of this today and part of that next week to break up some of that monotony. So, pharmacologic principles. From this exam going forward, anything in this specific lecture pertaining to any disorder can come up. I'm giving you that heads up right now, okay? So I just want you to be prepared that as we start talking through things, you need to know about medications. You need to know, what they do to somebody, or what would you expect to happen. And that's the point of this specific lecture. It gives you a general, broad overview of what we'll be looking through for the rest of the courses of this course. So, principles. The very first thing, a drug. Tell me a couple drugs that you know of. Metformin. You're going for the easy ones. Obviously, methamphetamine, metoprolol, Lasix, fluoxetine. All right, good. How about oxygen? Is that a drug? It absolutely is. Absolutely is a drug. You need a prescription technically to be able to give that to someone. You can't just, as a nurse, apply it. Now, there are policies and things that let you just put 2 liters on floors, but you already have protocols behind you helping you make that decision. It is something that's considered a drug that you have to prescribe, that you have to get a prescription for. So it is any chemical that affects physiologic processes of a living organism. So oxygen absolutely is a drug. It is considered therapeutic as well. Pharmacology, it's terminology, study or science of drugs. You already talked about that in the last one. And then legend drug. It's a prescription drug. That's what this term means, okay? Many people may not have heard of legend drug, but it's just a prescription drug. Another thing that you may or may not hear is called a research drug, and that's something that's currently being studied if it's brand new. Other things, just so you know, including in drugs, we have oxygen medications. You also have illegal drugs, alcohol, anything that will impair or affect physiologic processes. Now, legal considerations. You have 2 big organizations here, 2 big things here to look at. You have the U.S. drug legislation, which says what drugs are safe to give. What can we use? What can we use it for? This is specifically, this legislation is the stuff that lets us do that. The Nurse Practice Acts are what allow nurses to, or not, excuse me, will allow nurses to give something or prevent them from giving something. So who is responsible for giving the most medications and monitoring the patient is the nurse. Nurse Practice Acts say, this is what you give and this is what you can do. This medication you can give as a nurse, but something like propofol should be given by an anesthesiologist. While it's still a drug, it delineates it in a way that says, okay, a nurse can do this, but not this. Does this make sense? There's rules that you have on certain things you can and can't give without specific training. Okay, drug names. There's a lot of different things here. Chemical name, generic name, trade name. Who knows what N4-hydroxyphenylacetamide is? I saw some faces. I'm waiting. N4-hydroxyphenylacetamide. Not it. Come on. No, it's not nitro, but good try. Diuretic. Nope. It's Tylenol. It's the chemical name of Tylenol. Nobody calls it N4-hydroxyphenylacetamide. You go up to a pharmacist and say that, they're going to be like, huh? No, it's acetaminophen or Tylenol. We go with generic and trade. Your tests, your NCLEX, your ability to work is going to be based on the generic name of acetaminophen or the trade name of Tylenol. So that's how you study it. But I wanted you to recognize that chemical names specifically describe the chemical aspect of a drug. So you do not have to know chemical names. Tamar, don't worry about that. I just wanted you to know in case you decide to go on instead of looking at research, sometimes they put the chemical name down for this stuff. The only thing you need to worry about is generic and trade names for drugs. The reason I want to point this out, though, specifically with the generic and trade, is that patients need to know there are two different names of drugs. As we said, Tylenol and acetaminophen, but a lot of times you'll have patients come into the hospital and you're taking care of them, and the drug will look slightly different than what they normally take. Or they'll say, well, why are you giving me furosemide? Normally I take Lasix at home. You may not know, but those are the exact same thing. One's generic and one's a trade name. You need to be able to tell them that. Like, no, this is what the hospital purchases. It's the same drug. It's the same dose you take at home. And they're very adamant sometimes, like, no, I don't take it. No, I don't take it. You may have to call that provider and let them know, hey, they really want this generic, or hey, they really want this trade. But you can educate them saying, this is the same drug. This is just what we purchase from our distributors. We tend to use generic because it's more cost effective. How many classes of drugs do you think there are? Everybody's trying to read the slide. The slide does not hold the answer. About 20. There we go. We got somebody. About 20. There are only about 20 classes of drugs. Antihypertensives. There are antidepressants, anti-anginal. They have a lot of different, they have those. But then you have hundreds of subclasses. So the antihypertensives would have beta blockers, ACE inhibitor. You've got ARBs. You've got so many different things, loop diuretics, that just fall into place under subclasses. So I wanted you to know that when you start looking into drugs and start researching them, sometimes your books will say different things. Just start recognizing what they do, and that is a beginning of how you study these pharmacologies and these medications. And there's a lot more medications than there are, of course, subclasses. Recognize how these medications will be written. So antihypertensives, you may see HTN when talking about that, anti-HTN. Recognize that as a shorthand of antihypertensive. This is the beginning of a set of principal slides that define each of these three. Follow up as you're going through this. When you come to study these slides and look at it later on, this slide will help you kind of give you a blank to write next to, because all the other slides, all the other slides moving forward are going to kind of build off of these. Let me see. For something like Tylenol, if the patient has medication with them, take their own bottle. Nobody can take medication from home when they're in the hospital. If they have a rare medication or certain medications they do bring in, one that tends to save them money, because we can just send that down to pharmacy. They can dose their own medicine, and then they'll send it up to us. But even Tylenol has to be with us, and we have to give it to them, because you can overdose on Tylenol. So we want to make sure. If the hospital is out of it, then you have to ask them specifically to bring it in. Then you still have to send it to pharmacy, which they'll dose and put it in appropriately. You do not let them just take medicine from home. All right, so moving through this. Let's start with pharmaceutics. Home remedies, nothing from home. You do not need to know all 20 classes. I was just showing that to you, that there's a lot of them, okay? I wanted you to be able to read that that's a class of drug. Antihypertensive is a class of drug. A beta blocker is a class of drug. What about inhalers? Inhalers, usually what they'll do is you'll record an inhaler saying that they have it. Technically, unless it's an emergency inhaler, they shouldn't have it with them. Like, so if they have a daily one, they can do that. But technically, per policy, they should have their emergency inhaler with you so you can get it to them in an emergency. Okay, so pharmaceutics, the study of how various drugs forms influence the pharmacokinetic and pharmacodynamic activity. Kinetic is about what the body does to the drug. Codynamic is what the drug does to the body. And again, this will be expanded on as I move these slides forward. Okay. Pharmaceutic phase is the first phase of a drug action, also known as the dissolution of a drug phase. Okay. It's when the medications in the pharmaceutic phase are broken down to a point where your body can begin to utilize them and absorb. As I said, we're going to the second one. We've got pharmacokinetic, which once again was that what body does to the drug. The study, so we've got absorption, which is how it gets into the blood. Distribution, where it goes from the blood to specific body tissues. Metabolism, which is a change of medication, making it more or less potent, easier to remove, or even activate. Some drugs require metabolism to occur before the drug even works. And then how we excrete or eliminate the medication from the body. So absorption is how we get into the blood. Distribution is how we move to specific tissues or distribute. Metabolism is changing of the drug, and then your excretion is elimination of the drug from your body. Pharmacodynamics, fun word. The mechanism of drug actions, you got it. This is also called, what most of your books are going to call this, mechanism of action. When you start looking this stuff up, look for mechanism of action, because 99% of the books call it that, okay? What is happening to the body because the drug is present, okay? Pharmacology can be a very complex thing. So I'm trying to break this down, especially for those who have no background in this, trying to make this easier for you to begin to understand these terms. Is it helping? Is this making sense so far? Good. Good. Pharmaceutics. Okay. Dosage, form, design after dissolution. Okay? So if I give a medication orally, how long does it normally take for medicine to actually affect you? 40 minutes, 30 minutes. Based on your book, it's 30 to 60 minutes, and also depends on food, etc. But average for your book, PO meds, 30 to 60 minutes to really take effect, okay? How long does an IV med take? Seconds, instantly for the most part. These things work quickly because, again, they're right into your bloodstream. They don't have to be absorbed. They don't have to do anything. They're just ready to go and start acting on your tissue, okay? So let's just say I've got a patient who I'm taking care of. They've had pain for hours. I've given them everything I can, but we go to the next set of doses. It's now time for their medication. Their pain is 8 out of 10, which means they're really bad. They really want some medication for it. I have 2 pain medications available. I have a PO medication and I have an IV medication. I give them their PO medications for the pain. PO, excuse me. PO means put orally or put in the mouth, oral, okay? By mouth. I give them the medications orally. They're still in pain. Can I give them IV pain medication on top of that? No, need to prove it. You absolutely can. If you have the order to give those two medications on top of each other, which just requires both meds to be there, you can. Because PO takes 30 to 60 minutes to kick in. IV works, starts giving them treatment, but it tends to go away faster. So by the time the IV medication is going down, the PO meds are starting to kick in. Because the IV, Jennifer, good question. Why not give the IV first? Because the IV medication, you could give that first and then do the PO, but I'm specifically asking you the question, and don't jump in on these questions. I already said I gave him the PO. I asked if I can give him the IV on top of it. Okay? We want to be able to take through it. Yep. And then you can also have your breakthrough pain. The breakthrough pain is when we're talking, and we'll talk about that, but that's when you've treated them, and then more pain comes, is what we're talking about with breakthrough. So Jennifer, does that answer your question? I specifically said I already gave PO, so the question was, can I give IV on top of it? Yes, not a problem. This is the kind of questions you need to think through. This is what I want you guys to catch yourselves with. But it has to be written explicitly to give together. No, if I have a MAR that says I can give, that has both an oral version and an IV version, I can make that decision. I'll have to assess my patient to make sure I think if that's worthwhile, but I can absolutely give a IV medication after I give a PO. As long as their vitals can handle it and the patient can handle it, it'll take care of it. Yes, Brianna, this is called the ivory tower. I'm going to get a picture over here. And every time I do ivory tower, you'll see me do this. Ivory tower, this is what you would do in theory. Now, on here it says enteric coated. Anybody know what that means? It can be an extended release. Yeah, it's protected from the stomach. Enteric coated literally means a protection around it. So it won't just break up in the stomach, and it has to get down into the duodenum, jejunum for it to actually start being broken down and absorbed into the system. So when I get into enteric coated, there is something you always need to think. There's a lot of medications. When we talk about med administration, we'll talk about a little bit more about it, but there's a lot of meds that you can crush, you can cut, you can get the dosage right with that. If it's enteric coated or a capsule, do not ever break it, cut it, crush it, anything. It has to be given as is, or it will not work appropriately. It may go too fast, or it may not work at all. And as we said, there's a sustained release as well. That's the idea of it gets further in the system and slowly releases instead of all the medications being at once. Yes, coated so it doesn't dissolve in the stomach. Did I go forward too much? Truths. You see this slide? Star it, highlight it, know it for life. These are truths of your medicine, okay? Alterations in blood flow will influence absorption. If I don't have blood flow, if I have some sort of occlusion or blockage in my leg, and I have an infection on my toe, and I'm not getting blood flow, I don't care how much antibiotics I take orally, it's not going to get there. It can't be distributed because there's no flow there. Let's see. Our specific meds and so it'll be marked by, yeah, it'll say, most of the places say enteric coated, and you'll be able to tell pretty quickly on that, but it says it on there. And at certain hospitals, it even says, do not crush right on it. People's physiologies do alter how medications are absorbed. So as you begin, one person takes a medicine that goes right through them, they don't feel anything. Another person takes the same dose of another medication and it works really well for them. Your physiology can change. There's things called acetylators, and it's in this slideshow, but they make you either go really fast through medicine or really slow breakdowns. So it can alter how you take a medication. All medications need protein in some manner to actually take it somewhere. Protein is kind of like the bus. All your medications get on the bus or protein and get distributed out. If there's not enough protein, it can't be distributed where it needs to go, and they just kind of are there until your body gets rid of them. If a liver is diseased, a medication may be limited more slowly. So if somebody has a headache and I can give them Tylenol, acetaminophen, and they're in liver failure, you may not recognize this yet, but you can make them very sick from this because you need the liver for Tylenol to be broken down. And if your liver is not working correctly, that Tylenol is just building up in their system, causing damage. So you need to know, are they in renal failure? Are they having liver failure? What other problems are they having? Do they have only one lobe of a lung? What do we have with them? Because sometimes certain drugs require organs to be working properly, or they can't take them. They also have a higher risk of toxicity and overdose just from not having that ability to get rid of drugs. All right, absorption. It's how a drug is absorbed in the body. So the rate at which a drug leaves its site of administration and extent at which absorption occurs. So these are just two big good terms to know about. Bioavailability, which is how much usable drug makes it to the target tissue. When we talk about first pass effect, it'll make a little bit more sense with that. But the idea is when you take a medication orally, up to 60 to 90% of that drug never makes it to the tissue. So how much is available to actually work with? And then bioequivalency, that's just medications that are absorbed identically. So Tylenol versus acetaminophen. They're different, but there's a generic and a trade, but they're absorbed identically because they're pretty much the same drug. Bupropion versus Wellbutrin. The doses may be different, but the drug is absorbed the same. Definition slide. Passage of medication molecules into the blood from the site of administration. Again, absorption. Bioequivalent, I just defined that for you and gave you an example of it. Factors that influence absorption. Okay, so the route of administration, it can be absorbed through the skin or called transdermal, and that works. It's just a very slow absorption, which some medications need a slow absorption, so it works well with those transdermals. It is imperative for you to know that danger sign that I put in there. That is, IV is extremely rapid. We've already talked about that. It works well. It is short acting. But if you give it, you can't take it back. Whatever you put in IV, you better be ready because it's going to do whatever it's going to do to that patient. So you need to make sure the dose is right. Of course, follow all of your rights. You need to make sure you have everything correct before you give an IV. Because really there's nothing to do except support them and maybe give them an antidote if you did it wrong with an IV. The ability to dissolve. Solutions and suspensions. How does something break down? Are you going to give it orally as a liquid and then it breaks down more rapid? It makes it easier. Acidics. This deals with pH of gastric acid. Don't get lost in seeing if something requires a more acidic or base or alkaline stomach acid to actually handle it. You'll get that as you start getting into certain medications. We'll talk about food and what kind of drink it with. But just know that a medication may require a more acidic stomach or a more base stomach to actually be able to work appropriately. Blood flow. Again, if there is trauma and no blood flow somewhere, medications can't get to tissue beyond that. An IV stops working as soon as you stop administration. Slides are different. Pretty sure my slides are different than yours. Bradley, we'll take a look in a second. An IV stops working as soon as you stop administration. There is not an antidote for every medication. Sometimes you just have to support it. And I don't understand your question. An IV stops working as soon as you stop administration. We'll come back to that when you get a chance. Okay. Oh, when you stop the IV, how long does it take to stop working? That depends on this slideshow, something called half-life. How long does it stay in the body before it gets out of the body? So if I give it IV, it could last 14 seconds, which some medications do that. It could last months, depending on the medication. So it just depends on that half-life aspect. No problem. The short acting just means it doesn't last long, not that it stops. Correct. And again, we'll talk about a little bit more about how that all works in a moment. We'll get to the charts in just a moment. So we talked about blood flow to the area, body surface area. A large surface area will have more quick absorption. So in the small intestine, does anybody know how we absorb nutrients in the small intestine? What microscopic structure is there? Microvilli, absolutely. So if it gets down there, it's got all these different surfaces to help absorb it rapidly. Now, if I do it just in the stomach, you've got the rugae, which are giant folds, but not nearly as much surface area as the microvilli. That's what that's talking about. Think of the differences between rugae in the stomach and microvilli when we're talking about in the small intestine, because that's what we're talking about with surface area. And then lipid solubility. This allows you to actually go through highly lipid soluble, given with food. These are a little bit larger to absorb because the fat in the food, and it may require more time to actually digest or dissolve them. But that's why you make sure that they have food with them to help with that. Routes. So, how do we give a medication? We've talked oral. We've talked transdermal. We've talked about IV. Here's some more. Enteral. Here's how you think of it. Enteral. GI tract is what this is. Okay? Parenteral. And topical. Okay? Parenteral, it deals with anything that is not the GI tract. And then topical would be, of course, the skin areas, different surface areas. I'll give you some more examples in a moment. Here is a slide from an older book. I don't think yours has it anymore, but this is just kind of showing you what kind of routes are considered faster versus slower routes when we're talking about meds. So a syrup, an elixir, just tends to go in and start breaking down rapidly, where enteric-coated tablets tend to slow. It takes a while to get through just the stomach, so it's going to take even longer based on how they're designed to do. Enteral route. Enteral is Greek for intestine, is what this means. So the intestine route is enteral. Involves the GI tract anywhere from mouth to anus is the enteral route, okay? What is the difference in a liquid and suspension? Don't get lost in that. Wait for that. Liquid is just, again, something that breaks down quickly. Suspension usually has a liquid and a medication that doesn't mix well, but allows it to break down faster. Don't get lost in that. Just know that a liquid in suspension is going to break down and be absorbed faster than enteric-coated or a tablet. Page 16 of the book. Thank you, Ginger. Now, enteral routes tend to be, well, they don't tend to be. They usually are pretty nasty to taste. There's a lot of them that have a bad flavor to them. So sometimes they may need something to help, like an additive, which some pharmacies will do. They kind of make it taste a little bit better, but something to think about, like, hey, this patient really can't handle this. This is something we can do to help with the flavor of it. So now for that, you think oral, sublingual, buccal, rectal, okay? These are all part of the enteral route. Yes, Kiara, sublingual is considered enteric, correct. Even though it involves absorbing through the alimentary canal. It may go right into it differently, but it still deals with it. Does that make sense? Okay. First pass effect. Know this, understand this, okay? The metabolism of a drug and its passage from the liver into the circulation, okay? When a medication is taken orally, it goes through the alimentary canal, through circulation, into the portal circulation, and then hits the liver. At that point, drugs are then metabolized and distributed throughout the body as a newly metabolized chemical. After that chemical is used up, it's excreted after use. Up to 90% of a medication can be lost before it can even start being used on that tissue if it's taken orally. That is the first pass effect, okay? How would I bypass this? What would be a way you could think of bypassing the oral route and the 90% loss? Absolutely IV, okay? But absolutely IV, 100% of a medication, 99, 100, goes into the circulation if you give it IV. It just starts. It doesn't have to go to the liver. It's just ready to go and starts working on tissues. This is kind of giving you an imagery of how that works. For those of you who like the images. Those of you with experience back here, what is Lasix in general? We've talked about it a little bit today, so you can give me an idea. Diuretic, water pill. That's what you're going to hear, water pill a lot. Used to drain fluid from the body. Absolutely. For those who don't know what a diuretic is, it uses to drain fluid from the body. I can give a PO Lasix and I can give an IV Lasix. Which one's going to make you pee faster based on this? IV. Absolutely. Start thinking this way. That should make sense to you on what I just told you about. If I give you something, IV, it works faster. It doesn't have to go through anything. It just starts working on the tissue. Parenteral, also known as not absorbed through the alimentary canal. So this is IV, intramuscular, subcutaneous, intradermal, intraarterial, intrathecal, intraarticular, and transdermal. Yes, transdermal is in multiple spots. Intrathecal, think it's spinal cord. Intraarticular is into a joint. Topical. There's lots of different types of tissue on here, but it's all of these are considered topical. Okay? Skin, eyes, ears, nose, lungs, rectum, vagina, all can be considered a topical route for medications. With topical routes, you have to be careful. You have to think and watch for skin breakdown, open wounds, burns, because all of these things can alter how medication would be absorbed. Things like burns that are closed tend to increase absorption because there's more blood flow to that area. If you've got, cold skin, there tends to be a decrease in absorption because, again, less blood flow to that area. You tend not to apply medications to altered or broken down skin unless that medication is specifically for that area. I need a clicker check. Clicker check. Make it an easy one, though. When administering a drug via a parenteral route, the drug would be absorbed fastest if given per the IM route. False, 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 false. Absolutely, it is false. Can someone tell me what's wrong with this? IV. Yep. Yeah, it would be the IV would be the fastest route with parenteral. Good. Move on forward. Distribution. Again, another definition slide. This is getting medication where it needs to be. That's what this whole slide is. Factors that affect the ability of medications to get where they need to be. Distribution. Circulation. If you have decreased blood flow, you have decreased distribution. Again, it can't get somewhere that doesn't have a highway for the bus or the blood flow. Membrane permeability. If a lot of drugs don't cross that blood-brain barrier, it needs to be specific drugs to be able to cross that. Protein binding. Again, we need that bus. We need the protein there to actually distribute these meds. So we need good nutrition. We need to make sure that they have a good amount of nutrition, a good amount of protein to help with that repair, or just in general for those medications to work appropriately. For the metabolism, it's biotransformation. The drug is detoxified, degraded, and removed. The main organ here for metabolism is liver. The main organ for excretion is kidneys. So the liver does the work to break it down, make it water soluble, and excretion allows it to go away through the kidneys. This is just kind of showing the albumin, the protein. When you think about this, an analogy that was told to me, and I love this thing, was think about unbound medications as a teenager with no curfew and a key to a Mustang. They don't know where they're going, they just are going. Whereas if you bind them to the protein, they now have a curfew and they have a chaperone to get them where they need to be. Think of it that way. With albumin and with protein, I know where they're going and what they're doing when they get there. Metabolism, biotransformation. Transformation of a drug into an inactive, more soluble. This is literally a change of drug into something that makes it stronger, weaker, or just inactivates it. The main one, of course, being liver. We've talked about that. But the drugs, a lot of times PO have to get to the liver to be activated, to start working. Let's see, is there an issue with patients whose diet might have less protein than average, either by? Absolutely. So that's one of the big things I've been kind of hint at, is make sure your patients' diets are appropriate, because we want to make sure they're not like protein deficient, and then we're going to have a hard time getting the medications where they need to be to help them. So vegans and other ones who have these diet lifestyles, they're usually fine because they know how to get their protein appropriately. But people who don't, page 450, yes, that was one of my notes right here, can help with that as well. Oh, really quickly, back here, the effects of drugs, aging on drugs. This is just a quick overview of how things change in each part of this system based on becoming older. So you can take a look at this and quickly read over and so you have an idea. Something I want to highlight on here. Do you know when your kidneys begin to decrease in functionality normally? What age? Oh, if only it was 65. If only it was 50. 30. Between the age of 30, you begin to slowly decrease at the age of 30 with your kidneys. Remember, you have over 1 million nephrons inside of your kidneys per kidney. You will, at the age of 40, you'll start losing 1% of your kidney function every year for the rest of your life. Healthy or not, that's what will happen. Take care of your kidneys. But you automatically start having decreased functionality based on that as they get older. Your liver has a harder time with breaking things down, metabolizing medications. You have a higher risk of toxicity with that. Half-life, which we'll talk about in just a little bit, half-life actually takes longer. Certain medications can take longer than they normally have to get out of the system. Meaning if someone constantly takes a medication and their liver can't handle it, they can start to build up that medication and deal overdose and toxicity based on that. Yes, too bad you sold your kidneys for nursing school. Hopefully you got a good mechanical one. Yes, P450, C450. If you go for your bachelor's, you can go into advanced patho with me, and I'll be happy to talk to you about that, but let's leave that off the side for now. Yes, the more liver damage, the more chance of toxicity, because your liver, while it can regenerate, the cells have a harder time working with it. Okay, biotransformation. We kind of went into this, but looking back at that slide, this is just more of a highlighted version of it, but factors that decrease metabolism, renal insufficiency, cardiovascular problems, starvation, again, diet, slow acidylators. Don't jump into this. Acidylators are a graduate level class, but this is just an introduction. Just know it is a genetic variation that makes medications absorb or break down slower or more rapidly based on if you're a slow acidylator or fast acidylator. Yeah, so at 30, they start losing function. At 40, you start thinking 1% a year. With medications overall, always check contraindications when you start doing these things, when you start giving medicines, because someone who has renal insufficiency, certain medications, they just should not be taking it. You may catch that. The provider may order it and not think about anything, may not have checked it, and you'd be like, oh no, that medication specifically, they have renal insufficiency or they have liver disease. They can't take that medicine, and you have to call and catch that. And again, don't get too lost in the acidylators. Just introducing it because it is in your textbook. Just wanted to make sure you knew about the word. The medications themselves can also alter metabolism. Barbiturates can actually affect your enzyme ability. Rifampin can as well. So as you start taking medicines or giving medicines to people, they'll start changing during the medication, while the medication is actually working on the body. It can change how they absorb normally or act normally on the body. Okay, just continue on delaying it. So accumulation of drugs. So if somehow your body is forced to be slowed down, whether by medication, if you don't catch something like that, they can overdose or go into toxicity. So that's how you catch that stuff. If you're talking about like the renal disease, they can cause more damage and like lead to like liver failure, kidney failure. With the delaying, so medications themselves can also delay the metabolism overall, and that can lead to an increase in drug levels, leading to an increased risk of overdose and toxicity. Whereas sometimes certain medications increase the ability of your body to actually break down drugs, leading to when you take a normal dose, very little of the drug actually getting where it needs to be and decreased effectiveness of the drug. Excretion. Main organ of excretion is your kidneys. We've already said that. It gets rid of things, makes things get water soluble, and you get to micturate or urinate that out of you. There's a lot of other ones that deal with it though. This is just specifically how we get rid of metabolites. So lungs are actually used to get rid of anesthesia. So if you've ever had to use anesthesia, they usually give you oxygen and have you take deep breaths because it gets it out of your system much faster. Kidneys, again, main organ, liver, exocrine glands, breast milk. The bowels can help get rid of excretion. It's not as much as the actual kidneys do, but it does help get rid of some. The nephron. So I can't give you a mouse on this one, but no, there's the drug that goes in that afferent arteriole, which you can see up here, top left, goes through this entire goes to this entire nephron, and then gets excreted. Usually that drug metabolite doesn't change at all once it's in here. So that's how you can get drug tested, is everything's being broken down. They can check these metabolites because they're already in your urine. This just goes into different routes, target actions, how metabolism works. Again, it's just another image of what we talked about in this slide to kind of reinforce it. Halfway half-life. That's what we're doing right now. The half-life is the time it takes for half of the original amount of drug to be removed from the body. So certain medications have a 3-second half-life. Certain medications have a month half-life, and anywhere in between. With that being said, how many half-lives does it take for a medication to be completely removed from your system, or considered completely removed from your system? Yeah, you guys read the slides. That's what you did. 5, absolutely 5. That's a good one. That's something good to know, because, you know, if you know the half-life takes a month, it's going to take half a year almost for that fully to leave their system. So they have to be careful, especially when you get into mental health and you talk about antidepressants and all that. It takes a while for these things to get completely out of their system. Click a check. The client has been on low protein diet. This will most likely affect which pharmacokinetic process? Okay, I'm seeing a lot of different ones. So the answer here is C, for distribution, because the bus needs to be there for distribution to occur. And the bus would be the protein. So we have decreased plasma protein, distribution would be most affected by it. All right, movement throughout the body. Drug action is the cellular blah, 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 blah. Drug action is what happens to your body cellularly. Drug effect is what reaction is occurring because of the action. So drug action is what the drug does to you, and drug effect is what happens because the drug is there. You guys want a small break? Yes, let's say 2:30. So it's 2:23 right now. We will start again at 2:30. All right. Needed that breather for just a moment. I was reading a lot of questions on drug action versus drug effect. Again, just think of it as your drug effect would also fall under the same term as pharmacodynamics. It's just something to study and realize that a drug effect, what it does to the body, and the action is how it's cellularly changing. Is it releasing prostaglandins, or is it inhibiting something? Is it stopping something from occurring? That's what a drug action is. And because of that action, the effect would be pain relief, or the effect would be increase in urination if we talked about that. Does that make sense? Yes. Okay. Thank you. Moving on through. We've got less than half an hour. Yes, the drug action causes the drug effect would be the easiest way to think about it. Okay, let's move on through. All right, onset, peak, and duration. So onset is how long it takes for medication to start working. We're going to have a slide, and the next slide is going to go over this in more of a visual manner, but I'm going to go through it really quickly. Where peak is the time it takes for a drug to reach its maximum therapeutic response, and duration is the time a drug concentration is sufficient to elicit a response. So prior to metabolism, the time a drug concentration is sufficient to get a response out of it. Again, the textbook definition doesn't do it justice compared to this. So onset of action is this bottom left. During that time period, that onset of action before the curve turns blue, that's when the medicine's in, but not doing anything to help because there's not enough of it there. Absorption to peak level down through that elimination to the bottom of that curve, or to the bottom of that line, is when the medicine's affecting the person in some way. And the termination of action, the medication is no longer doing much, but it's still in the system. So think of this as IV. The timeline here is very generic on this table, but IV, it's going to go in, mechanism of the administration, and then you're going to have an onset within seconds. And then, but it's going to hit that peak pretty quickly and then drop out of there and distribute out of the system really rapidly. So it's very limited duration. Where PO, this onset of action can take 30 to 60 minutes, but it can last much longer before it hits that point. So when you start treating people for pain and you hit that peak level and their pain medicine starts wearing off, they'll tell you, hey, it's starting to go up a little bit. You may need to give them something where that elimination word is. They may start feeling it to the point where you can feed it, you can give it to them then. So as that first medication wears off, all of a sudden we hit the front of that curve again where the word absorption is, and that second dose of medication is starting to help them. That's how we try and make sure people are treated appropriately with pain medications, antibiotics, whatever we're treating at that time. Pain medication tends to be the easiest way to think about this because a lot of people have at least heard about how pain medication takes that feeling away and how it can come back slowly if the pain medication isn't controlled. All right, ways drugs produce therapeutic effects. Once a drug reaches wherever it needs to be, it modifies the rate of a tissue. It does not alter a cell or tissue to do something it can't normally do. You can't have medication hit your skin and make it act like cardiac tissue. It doesn't do that. It may grow skin more rapidly, or you can't have cardiac tissue act like a kidney. It doesn't work that way. You can only alter what the cells there can already do. DNA in those cells are the things telling them what it can do. So you're just going to alter those, whether it be increase it, decrease it, stop it. How to regulate, chart, use of a... Oh, we'll talk about PCA pumps when we get to pain. Don't worry about that right now. That's its own thing. But it does fall under that. I just don't want to go into PCA pumps in this lecture. But you'll get there. Don't worry. All right. Mechanism of action. Receptor interactions. Again, there'll be an image in just a second. How drugs bind to cell membrane receptor. You've got enzymes, non-selective. So again, the idea here is we activate an enzyme or tissue. We stop or slow its current ability to do something. We inhibit interactions between cells and enzymes and chemicals, or make them more rapid, depending on the medication. Back to your micro days, you've got your enzymes, your agonists and antagonists. You've got keys that can start things and get the actual reactions occurring, or you've got antagonists that stop everything from happening. So agonists are like a key that start reactions, and then your antagonists are like ants at a picnic. They make everything stop because it's no longer fun at a picnic if you're covered in ants. A very common medication is this purple one in the middle. It's called an ACE inhibitor, okay? We use it for blood pressure medications. The idea here is it stops a reaction from occurring in the RAS system. I'm sure you all loved that system. RAAS, renin-angiotensin-aldosterone system. We will talk about that later on there. But the idea here is this. I'm trying to give you an example of when you're in the lungs, you have all these reactions occurring. ACE starts to work. It's called angiotensin converting enzyme. It starts working. It helps with blood pressure. If an ACE inhibitor is there, it stops that from happening, allowing blood pressure to stay lower. That's the purpose of an ACE inhibitor. We're using that as a medication example. So falling back to what I was saying, we can't make it do something it can't already do, but we can stop ACE from working, therefore altering how everything else happens. The ACE inhibitor will stop the ACE from occurring, or the angiotensin converting enzyme. By stopping that reaction, we allow blood pressure to stay lower. So that's just an example of one of many, many different reactions you'll learn about. So this is just the types of therapy. These are just definitions you'll need to understand as you go through it. Acute is rapid, life-sustaining. Maintenance therapy is just preventative progression. Supplemental, this would be like electrolytes and blood. Palliative care or hospice for comfort. Supportive therapy can be oxygen or yogurt. Prophylactic therapy, immunizations and blood thinners to prevent problems. And empiric therapy would be like giving a broad spectrum antibiotic before we know the actual antibiotic that's necessary to target the infection. Again, this is just a definition slide. Have an idea of what these terms mean. Contraindications. Every single drug, and I have looked at them through how many sources now. I'm still trying to find one. Every drug has some sort of contraindication. Your job is to know before you give it, what is said contraindication? Is it a lab value? Is it a second medication that you're going to give through it? Is there skin breakdown or altered absorption ability? Age restrictions? Something. There is always something that contraindicates a specific drug from being able to be given. And you need to make sure you catch those things. So I want to make sure that you know to watch for contraindications. By the way, if somebody's allergic to something, don't give it. It's a contraindication. A lot of times people don't check that. Always check your allergies with that. All right. Know these terms. Highlight them, star them, know them. Okay? Whenever you review any medication, these are going to be part of what you need to know for every single drug. Therapeutic effect. What is it supposed to do when you give it? Why am I giving this antibiotic? I'm giving it to get rid of this infection. What is the purpose? It is to get rid of something or to do something. What's the side effects? Predictable. So if I give a medication and let's say I give somebody an antihypertensive like metoprolol and they get a little dizzy, that's a side effect. I'd expect that because their blood pressure is not as high as it once was. Then you have your adverse effects, which is unintended, unpredictable things that occur. Like if you start having a complete on allergic reaction, adverse effects. If you have a heart attack after taking certain antibiotics, adverse effects. And then toxic effects is if you take too much. Again, this is more related to what we're talking about with excretion. Can we get it out of our body fast enough? Or do we have a decrease in respirations, making it difficult? So, little story. I'm sure some of you have heard this, but what was the original purpose of a drug called Viagra? Yeah, okay. So ED is the current purpose. Originally, it was researched for pulmonary hypertension. Absolutely, blood pressure. It helped with that. But a side effect that they found in men was it caused an erection. So now the erection is the therapeutic effect, and the side effect is low blood pressure. When you start talking about meds, look at this red word, this red sentence here. What do you do if your patient has an adverse reaction while you're infusing something? What would you do? Absolutely. Stop whatever is causing the infusion, or excuse me, stop whatever is causing the adverse effect or the allergic reaction. Don't flush it into them where you get another 10 mils because you want to flush the line. You want to stop the infusion before you call the provider and start doing things. You need to make sure that whatever is causing the problem has been stopped. And then you call the provider. All right, more actions. You have idiosyncratic reactions, overreaction or underreaction. You've already talked about this in the last lecture a little bit, but this is kind of reinforcing that. You have your over or under reactions or causing no reaction. Things like Ritalin. If you give Ritalin to a child, it relaxes them. If you give Ritalin to an adult, it stimulates them. Allergic reactions, again, stop infusions if that kind of situation happens. Medications that affect when two meds are together. So you've got synergistic. So an example of here would be narcotics and alcohol. What's going to happen to the respirations of somebody who's taking narcotics and alcohol? Very slow. Yes. Yes. We're going to have some hypoventilation. How's their level of consciousness going to be? No, we haven't gone into that too much, but we're going to have low. It's going to be harder to talk to them. When we try and speak with them, you may have slurred speech. You may have to physically like move their shoulder, get them to actually talk, and then they go back into that sleep mode. It just depends on what's going on, that synergistic effect. And then dose responses. A lot of times there's half-lives that require medications to be given at specific times to make sure you take care of it. Antihypertensive, what about that, Ravina? Oh, antihypertension. Yeah, that means antihypertension. That's just HTN is shorthand, medical shorthand for hypertension. No problem. And if you guys catch any of that stuff you don't know, I try and say it when we're going through it. But still, feel free to ask just in case I miss it, okay? So again, the medication dose responses, this may be one of those medicines we have to give every 8 hours or every 4 hours, every 12 hours to make sure that the dose is not too high where we cause the toxicity or overdose, and it's not too low where they're not getting a therapeutic effect. When you when you give medications to a patient, you need to know what you're looking for. You need to know, what would you expect if the medication starts working? What would you expect if the medication doesn't start working? Would you expect, what were some side effects? What are some adverse reactions? Things that you will constantly have in your mind where if it happens, you're like, okay, I already expected that to happen. Would you expect soreness from a patient or halos, tingling sensations? Based on the medications, you'll need to know that kind of stuff, because if you start giving medication and somebody gives you a reaction you have no idea, now you're going to have to go look it up and see, oh, what was that? What is going on with this? So we want to make sure we know what's going on. We're going to go into each of these in just a moment, but therapeutic index, if there's enough medications or not enough medication to be therapeutic, do they have what they need for the medicine to work? And that deals with drug concentration, how much is actually there in the body. Patient's condition, you need to watch to make sure the patient's actually changing or at least being stable with that medication. We're going to move on just to the next slides. So we've got monitoring, therapeutic index, ratio, again, of a drug's toxic level versus therapeutic level. We want to make sure they stay in that therapeutic, that they have enough medication, but they don't have too much to become toxic. Tolerance is a decreased response to repeated drug doses. So if they are constantly, the easiest one to think about this is narcotics or any sort of IV drug use, but they constantly use and they stop getting the effect of the pain medication, so they need higher doses to actually take care of that. Versus dependence, where they actually have a physiologic or psychologic need to take that drug. Again, falling onto it to make it the easiest to think through, you think of like IV drug use or any sort of drug abuse where they get to the point where their body starts requiring it before they start having symptoms if they don't take them. Peak and trough, you will see this in a lot of antibiotics that are higher. Like when you start talking about vancomycin, you will see peak and troughs because this drug has such a small therapeutic window and such a easy amount of, it's very easy to become toxic or overdose or destroy somebody's kidneys with this drug. Absolutely, Ginger, vanc. So you have to make sure that you take a peak. If you look at this chart, peak, as we said in the last one, is the most amount of drug there. That's where we want them to stay at. And trough is the least amount. So a few hours, usually a small amount of time after taking vancomycin, you'll take a blood draw, which is when the most amount of the medication will be in their system, the peak. The trough, you'll take a blood sample right before you give them the next dose of vanc, which is when the lowest amount of that vancomycin should be in their system, or whatever drug you're monitoring this way. Regardless, the point is especially for these drugs that have very narrow therapeutic windows or very narrow amounts of drug levels, we have to constantly be watching, and the providers will constantly be altering the dosages based on how their body's handling these very strong drugs. Pharmacy, you give orders. It'll usually depending where you are, it'll pop up saying, you need to have this. Pharmacy may not even send you the dose if you don't have that drawn appropriately, because they have to usually change the dosage based on your results. You're welcome. Okay, keep going with the medicines. Is a herbal medication a prescription or something that needs to be, let me say it this way, is an herbal something that should be reported to you as a nurse when you ask about medicines? Absolutely, yes. And you need to make sure, because if you say to somebody, hey, do you take any home meds? No. Do you take any herbals? Well, yeah, you didn't ask about that. I take foxglove, and I take saw palmetto, and I take licorice, and I take this. You need to make sure, you always ask, do you take any medications or herbal drugs to help you? Because a lot of these drugs can interact, especially things like, if you hear St. John's wort, be ready, because there's a lot of interactions with that one. You need to know any home remedies they're taking. I've had a cough for 3 months, but Grandpa gave me his elixir he makes every summer. Well, what's that? Oh, it's THC and whiskey. Oh, I kind of need to know that. That's something I probably shouldn't be giving your 12-year-old with that. Primrose oil affects potassium. Yeah, there's a lot of different things you will hear. By the way, anything I tell you about examples are things I've heard. So just be prepared. Moonshine and honey. Okay, come on. We don't need moonshine and honey with this cough medicine. It is not something we want to do right now. So yeah, there's a lot of different things that you'll hear, and you'll hear all about it. That's why we asked about you. We've asked this stuff of you earlier. What do you use? What kind of stuff do you think about? And be careful not to give advice about these things, because you want to make sure that they know that they can interact, but you don't want to start giving them advice on it, because then you're practicing outside of your scope of practice. Mama called it potion. Yeah, I hear about that. All right. This slide is just a definition slide, but it is something to know about for definition. So additive effect. If I give two medications, they work in tandem. So 1 and 1 is 2. Demerol and Phenergan works well with my nausea and my pain, but doesn't go any higher. Synergistic effect. This is 1 is 1 is 9, 12. This is alcohol and narcotics. Don't combine unless you need it. We gave a nice one of hydrochlorothiazide, HTC, and lisinopril for blood pressure, but a lot of people will think synergistic effect with narcotics and alcohol and other narcotics. So again, think synergistic. Things worked way stronger than they would if they were just be separate. Antagonistic, 1 and 1 makes less than 2. Things don't work as well as they should have. Antibiotics and birth control, antagonistic effect. Incompatibility leads to chemical breakdown. Pantoprazole and Zosyn. When I find this, I'm trying to get an image of this, but literally, if you were to pull up pantoprazole, because you can give this IV, and you put it in through a Zosyn line that has Zosyn in it, it becomes literal snow crystals inside. Don't let it get into the patient. I've had to stop many people before I hit that patient. I'll get a whole new line. If you see things starting to change before it hits the patient, don't let it hit the patient unless you know it's supposed to do that. So let's do some questions. We got one here anyway. Per physician order, you have administered a combination of analgesic drugs that together have stronger effect than either of them given individually. Which of the following most accurately describes the phenomenon? Oh, yes, thank you. It's not like I just spent 2 minutes talking about this one. Ported multivitamin use doc when they prescribe Zoloft. Stroke at 20. Yeah, absolutely. Absolutely, Stephanie. There's a lot of things that can happen. You've got to be careful. Yes, it is C, synergistic relationship. Just to kind of continue the monitoring aspect. Pharmacologic reactions include adverse effects, what happened, what can occur, hypersensitivity reactions, allergic reactions, idiosyncratic opposite. This is more of a review slide, and drug interactions. I don't know who's answering before the slide shows up. Drug-related effects. These are definitions, so make sure you know them, but teratogenic means results in fetal defects, mutagenic, genetic composition change, and carcinogenic, cancer causing. You'll hear these. As you go through, you will hear these terms, especially carcinogenic. When you get to OB, you'll get more about this stuff too, but I want to make sure you know about these classifications of drugs. Make sure you know about the classifications of drugs, because you want to make sure you know category X is contraindicated, where A is safe, and recognize what they each mean in terms of safety for a fetus. And I put a couple on there just to kind of have, I like this one just because it gives it a little more of a simple breakdown. I like, and N, don't worry about N. We don't know. Dave's too busy to feed on it to the rats right now. That's what N is. So usually they're all A through X at this point. So pharmacognosy, or knowledge of drugs, just have to know that there's 4 main sources of drugs. They're either plant, animal, mineral, or we just happen to make it. Oh yeah, there's some fun ones now. Toxicology, study of poisons and unwanted response to drugs and other chemicals. Again, definition. You will never, unless you become part of the CDC as a nurse, know all the antidotes for every drug. I have tried unsuccessfully for years to make a PowerPoint of every antidote for all of these different things. It just keeps changing. So just know that if you're in the ER, even up in the med surge, and someone takes something, the provider's not going to know it necessarily either. You know, certain ones like acetaminophen with acetylcysteine, that makes sense. There's certain ones you can do, but for the most part, they're like, oh, I took 50 ibuprofen and 20 Benadryl. Well, what do we do with that? Call poison control. We do it all the time in the ER, and we're like, hey, we're in the ER. What do we do with this? Absolutely fine to do. Do not memorize this because it will change in a day. I'm just showing you that there's lots of different poison antidotes. It's a couple easy ones to remember, but call poison control with poisons. Clicker check. Student nurse is studying the phases of drug action. Which statement by the student indicates the nursing instructor? The student understands the pharmaceutic phase. Correct. B. For the drug to cross biologic membrane, the drug becomes a solution. Absolutely. One more. You administer IV morphine to a client who's in severe pain. 5 minutes later, you hear him sigh deeply. Is the morphine kicking in now, you ask? Yes, he replies. If in this case, 5 minutes represents which of the following? Good. I'm seeing A's and C's. The moment he feels better is the onset of action. The moment the drug hits the peak of its action would be C, peak action. He starts feeling better. That means the drug's finally hit that onset of action. The end. Woo! We did it. Now